Welcome to our ECG Masterclass. This is a deep dive designed specifically for you, the anesthesiologists in the thick of it. We're going to skip the fluff and get straight to what matters: how to rapidly diagnose and manage the critical cardiac events you're going to face in the perioperative setting. Think of this as your playbook for the moment that rhythm on the monitor changes and everyone in the room looks to you for an immediate, expert response.
So here's our game plan. We're going to build this from the ground up. We'll start with the absolute fundamentals of the ECG and do a quick survey of the common arrhythmias. Then we'll put some key tachyarrhythmias head-to-head. After that, we'll decode the tricky world of AV blocks and then dive into ST segments and ischemia. And we'll wrap it all up with the emergency algorithms you need to have locked in. Let's get to it.
All right, let's kick things off with part one. We have to start at the source, right? We're going to reinforce the fundamentals, what the ECG is actually telling us, how to make sure we're getting a good signal in the first place, and then we'll take a tour of the common arrhythmias you'll see pop up on your monitor.
So, at its very core, what is an ECG? It's basically a movie of the heart's electrical system in action. For us, in the operating room, it's our continuous, real-time lifeline. It's how we tackle three absolutely critical jobs: keeping tabs on the heart rate, spotting an arrhythmia the second it starts, and, crucially, detecting the subtle signs of myocardial ischemia. It's our eyes on the heart.
You know, the real power of the ECG is just how much it can tell you from a few simple squiggly lines. This table breaks it down into two big buckets. On one side, you have the anatomical stuff. You're getting clues about the heart's actual structure. Is it ischemic? Is it thickened from hypertrophy? On the other side, you get this incredibly deep look into its physiology. How is it conducting electricity? Are electrolytes out of whack? What are my anesthetic drugs doing to the system? It's a phenomenal diagnostic tool.
Now, let's talk about something that feels basic, but honestly, if you get this wrong, everything else we discuss is useless. I'm talking about lead placement. You've got Einthoven's triangle for your limb leads on the left and the precordial or chest leads on the right. These are not suggestions, they're precise anatomical landmarks. It's a classic case of garbage in, garbage out. If your leads are in the wrong spot, you're going to be chasing ghosts and might make a completely wrong diagnosis.
Okay, this right here, this is our ruler. This is the baseline we measure everything against. Before you can spot the abnormal, you have to know the normal cold, so let's lock these in. Your PR interval, that little delay at the AV node, should be between 0.12 and 0.20 seconds. Any longer, you've got a block. The QRS complex, ventricular depolarization, needs to be fast and narrow, 0.10 seconds or less. If it's wide, the signal is taking a weird detour in the ventricles. And your corrected QT interval, basically the whole ventricular action, should be under 0.44 seconds. Any deviation from these numbers is your first clue that something's up.
All right, let's start our tour of arrhythmias at home base, rhythms that come from the sinus node. As you can see in this table, they all share the same DNA, a normal PR interval and a nice, narrow QRS. The real difference is all about speed and timing. See sinus tachycardia? That's your monitor screaming fast. Your first question shouldn't be what drug to give, but why. Is the patient light, in pain, hypovolemic? Then you've got sinus bradycardia. Super common, right? You'll see it all the time with vagal stimulation from surgical manipulation. Sinus arrhythmia is usually no big deal, just the heart rate speeding up and slowing down with breathing. But the one that should make you sit up straight is sinus arrest. That's when the pacemaker just takes a break. It's a critical pause, and you're watching, waiting, hoping a reliable escape rhythm is going to kick in.
Okay, now we're moving out of the sinus node and into the atria, where things can get a little chaotic. The two big ones you'll see constantly are atrial fibrillation, that's the classic irregularly irregular rhythm with no discernible P waves, just a shaky baseline, and atrial flutter, which is more organized, giving you that telltale sawtoothed pattern. You might also see paroxysmal atrial tachycardia, or PAT, which is frustrating because it starts and stops out of nowhere. And then there's a special one, Wolff-Parkinson-White, or WPW. It's a pre-excitation syndrome. You'll spot it by the short PR interval and that little slurred upstroke on the QRS, the delta wave. Knowing if your patient has WPW is so important because some of our go-to anesthetic drugs can actually accelerate conduction down that accessory pathway and cause real trouble.
All right, let's go downstairs to the ventricles. And this is where arrhythmias go from concerning to immediately life-threatening. The calling card for all of these is a wide, bizarre-looking QRS complex. That's your signal that the impulse is coming from the ventricle itself, and it's an inefficient, ugly beat. It can be a single premature ventricular contraction, a PVC, which on its own is often benign. But if you start seeing a bunch of them in a row, that could be the prelude to ventricular tachycardia, a true medical emergency. A special twisting form of VTAC is torsades de pointes, which you see in patients with a long QT interval. And then there's ventricular fibrillation. This isn't a rhythm, it's just electrical chaos. The heart is quivering, not pumping, and this requires one thing: immediate defibrillation.
Okay, for the last part of our survey, let's talk about the heart's electrical highways, the conduction pathways. With these disorders, the problem isn't where the beat starts, it's about how it travels. Think of it like a traffic jam. A first-degree AV block is just a minor slowdown. Every car gets through, but it takes a little longer. A third-degree block is a complete road closure. The atria and the ventricles have stopped talking to each other completely. They're totally independent. And in between, you have things like bundle branch blocks, LBB and RBB. That's when the signal has to take a detour through one of the ventricles, which is why you get that wide QRS.
All right, we've surveyed the landscape. Now let's put some of that knowledge into practice and really zoom in. We're going to compare 3 of the most common tachycardias you'll see. Being able to tell these apart quickly and accurately in the middle of a case, well, it's one of the most vital skills you can have.
This table, right here, this is your mental cheat sheet. It boils the whole diagnostic process down to just 3 questions. Let's walk through it. First, sinus tach. Is it regular? Yep. Are there P waves? Yep. One for every QRS. Is the QRS narrow? Yep. Check, check, check. Okay, now atrial fibrillation. Is it regular? Not a chance. P waves? Gone. QRS? Still narrow. See the difference? And then you have the big one, ventricular tachycardia. The huge red flag, the thing that sets it apart, is that wide and bizarre QRS. This is your rapid-fire grid for when the heart rate is screaming. And here's what it looks like on your monitor, side by side. On the left, you have sinus tachycardia. Yeah, it's fast, but look at it. It's organized. It's a steady, marching rhythm. Every QRS has its P wave, its order. Now look to the right at atrial fibrillation. It's pure chaos. There is no pattern. The baseline is a mess. The R to R interval is all over the place. The visual differences is just, it's immediate and stark. It's order versus chaos. I want you to burn this 3-step process into your brain. When that heart rate suddenly jumps to 170 and the pressure starts to fall, this is what you do. You don't just stare at the screen and panic. You systematically ask yourself these 3 questions. 1. Is it regular? 2. Is the QRS narrow or wide? 3. Are there P waves? This simple, systematic approach will keep you calm and guide you to the right diagnosis and the right treatment every single time.
Let's shift gears now and do a deep dive into AV blocks. This is all about the communication breakdown between the atria and the ventricles. It's a whole spectrum, from a tiny delay all the way to a complete severance of that connection. And understanding this progression is absolutely key to knowing which patients are stable and which ones are about to deteriorate on you.
I like to think of this as the AV block ladder, where each rung represents a higher clinical risk. At the bottom, you have first-degree block. The PR is long, but it's constant, it's low risk. Then you climb up to second-degree Mobitz I. This is the classic longer, longer, longer drop, Wenckebach phenomenon. The risk here is low to moderate, but then you get to Mobitz II, and this is where the risk jumps dramatically. Why? Because the beats are dropped suddenly, unpredictably, without any warning from the PR interval. This one has a high risk of suddenly progressing to a third degree or complete heart block, which is a true emergency.
And this strip shows Mobitz type 2 perfectly. Let's trace it out. Look at the PR interval here, and here, and here. They are exactly the same, they're constant. And then, bam, you get a P wave all by itself with no QRS after it. It came out of nowhere. There was no warning, no progressive lengthening like in Mobitz I. That sudden, unexpected dropped beat is the hallmark. It tells you the problem is deep in the heart's wiring, it's unstable, and this patient is at high risk for complete heart block.
Okay, let's move on to something that is absolutely bread and butter for every anesthesiologist, the ST segment. This is our main window for seeing myocardial ischemia in real time. But here's the catch. It's not always straightforward. So we need to get really good at telling the difference between true ischemic changes and some very convincing mimics.
The most important takeaway here is that not all ST deviation means the heart is dying. Your job is to be a detective. True ischemia tends to show up with localized changes in specific lead groups, and they're dynamic. They're happening now, and they're changing. You'll often see reciprocal changes in the opposite leads.
This is completely different from something like a chronic left bundle branch block, which can cause massive ST changes all over the ECG, but they were there yesterday and they'll be there tomorrow. It's all about context and looking for change.
This is a fantastic example of a mimic. Take a look at this 12 lead from a patient with a pneumothorax. You see this right axis deviation, you see low voltage in the chest leads, you see these T-wave inversions. Now, if someone just handed you this ECG with no context, you might be thinking about a big ischemic event. But then you put your stethoscope on the patient's chest and hear absent breath sounds on one side, and suddenly the whole picture clicks into place. It's a perfect reminder to always treat the patient, not just the monitor.
So what do you do when you've done your due diligence and you're sure it's true ischemia? You need an action plan. Here's the drill. Step 1 is the initial response. Get the basics right, and get them right fast. That means optimizing oxygenation, controlling hemodynamics, get that blood pressure up and the heart rate down, and make sure the patient has enough analgesia. Step 2, you do not take your eyes off that patient. You are continuously assessing their hemodynamic stability. And step 3, you anticipate what's next. An ischemic heart is an irritable heart. It's prone to arrhythmias, so be ready to treat whatever it throws at you, whether it's bradycardia or tachycardia.
Okay, we've built the foundation. We've talked about the what and the why. Now we get to the most important part, the playbook. This is what you do when things go south. In a crisis, you don't rise to the occasion, you fall to the level of your training. So let's lock in these clear, actionable algorithms for bradycardia and tachycardia for when every single second counts.
Here they are, your roadmaps for a crisis. On the left is the bradycardia algorithm. The first and only question you need to ask is, are there adverse signs? Is the patient hypotensive, altered, in shock? If the answer is yes, your first move is atropine. If that doesn't work, you're immediately thinking about pacing or drips like epinephrine or dopamine. Now look to the right, the tachycardia algorithm. The absolute first branch point is the patient stable or unstable? If they are unstable, chest pain, shock, heart failure, the answer is always the same. Synchronized cardioversion. Electricity, now. If they're stable, great. You have time to breathe, look at the QRS width, and work your way down the rest of the algorithm.
So, as we wrap this all up, after all the tables and the rules and the algorithms, I want to leave you with this one final thought. These things are essential guides. They are your playbook. But in that critical moment, with a patient who is rapidly deteriorating, your ultimate job is to blend all of this knowledge with what you are seeing, hearing, and feeling from the patient in front of you. You have to constantly ask yourself, am I treating a number on a screen, or am I treating this patient's physiology? Making that connection, that's what makes you an expert. Thank you for joining me for this explainer.